Welcome. In this session, we are going to start our discussion on lacrimal disorders. In this session, we are going to discuss about congenital lacrimal disorders. In the next session, we are going to take up acquired lacrimal drainage obstruction. And in the third session, we will discuss the other acquired lacrimal disorders such as trauma, infection, and neoplasm. Among the non-obstructive developmental anomalies of the lacrimal apparatus, we have absence or hypoplasia of the lacrimal gland, which is a rare entity and can be sporadic or autosomal dominant. Ectopic lacrimal gland tissue can occur in the orbit or in the eyelid. Congenital prolapse of the lacrimal gland is associated with craniosynostosis, and aberrant lacrimal ductules exit through the eyelid skin above the lateral eyelid margin. Around the openings of these aberrant lacrimal ductules, there can be hair follicles, and these aberrant lacrimal ductules cause epiphora. In duplication of puncta and canalicular system, if the extra puncta is on the eyelid margin, it is usually asymptomatic. But when the extra puncta opens on the skin, usually inferonasal to the medial canthus, it is called a lacrimal-cutaneous fistula, as seen in this photograph. And this lacrimal-cutaneous fistula is usually connected to the common canaliculus or the lacrimal sac. A lacrimal-cutaneous fistula presents with epiphora when it is associated with a congenital nasolacrimal duct obstruction. Otherwise, it is usually asymptomatic. So, a lacrimal-cutaneous fistula can be treated by probing the nasolacrimal duct to relieve the obstruction in the nasolacrimal duct, but if the symptoms still persist, the epithelium-lined fistulous tract is excised, followed by skin closure. Clinical features of congenital lacrimal drainage obstruction include tearing with or without mucopurulent discharge and swelling in the medial canthal area. Tearing usually starts several weeks after birth. If there is constant tearing with minimal discharge, it usually suggests a puncta or a canalicular obstruction. However, constant tearing with frequent discharge suggests complete NLD obstruction, and intermittent tearing with discharge suggests intermittent NLD obstruction. If there is a congenital Dacryocystocele formation in the lacrimal sac from NLD obstruction, we typically get a swelling below the medial canthal tendon. In contrast, swelling above the medial canthal tendon suggests another diagnosis such as encephalocele or dermoid cyst. Digital pressure over the lacrimal sac area is a very important test which should ideally be done in every patient with epiphora, and reflux of mucoid or mucopurulent discharge through the punctus suggests a complete obstruction of the nasolacrimal duct. Differential diagnosis of epiphora in an infant or a young child includes ocular surface abnormalities such as conjunctivitis, keratitis, or a foreign body, lid abnormalities such as trichiasis, entropion, or epiblepharon. Congenital glaucoma is a very important differential diagnosis to exclude in a child presenting with epiphora. In congenital glaucoma, epiphora is associated with photophobia and blepharospasm in a classic triad, and corneal enlargement and corneal clouding can also be present in congenital glaucoma. Photophobia, blepharospasm, corneal enlargement, and clouding are not seen in patients with congenital nasolacrimal duct obstruction. Hypoplasia and stenosis of the puncta is more common than a true aplasia of the puncta. A membranous punctal obstruction can be opened by probing and intubated to prevent recurrence of the obstruction. Associated absence of the punctal papilla, which is the elevation over which the punctum is normally located, suggests presence of associated canalicular obstruction. In true aplasia of the punctum, no punctum is detected as shown in this photograph, and intubation of the canaliculus through the skin has to be done. Canaliculus can be identified by incising through the eyelid margin just medial to the expected position of the punctum, or by retrograde probing through an open lacrimal sac. Marsupialization of canaliculus onto the tear leg is not considered to be effective, and intubation of the lacrimal system through the open canaliculus, as shown by the green line in this photograph, should be done. When puncta and canalicular system are abnormal or absent, a conjunctivodacryocystorhinostomy, also called CDCR, needs to be done. in which a channel is created from the conjunctival sac near the medial canthus through the lacrimal sac into the nasal cavity, and a Jones tube is inserted into this channel. A CDCR can be done only when the child is old enough to allow care of the Jones tube, because the Jones tube needs to be periodically removed, cleaned and reinserted. We will be discussing CDCR in more detail in the next session. Congenital nasolacrimal duct obstruction, also called CNLDO, is most commonly due to a membranous blockage at the level of valve of Hassner at the distal end of the nasolacrimal duct, when it is called a simple CNLDO. Less commonly, CNLDO is associated with facial cleft deformities when it is called a complex CNLDO. It has been found that 22% of Down syndrome patients also have CNLDO. 2 to 6% of full-term infants have CNLDO and are symptomatic by 3 to 4 weeks after birth. Among them, 1/3 have bilateral CNLDO and more than 90% resolve spontaneously by recanalization through the valve of Hassner within 1 year of age. Among the remaining 10%, 90% are cured by probing, as we will be discussing. Clinical features of CNLDO include epiphora, mucoid or mucopurulent discharge, and crusting of the eyelid margins. The symptoms are worse with chronic nasal congestion, because the congestion also involves the mucosa of the nasolacrimal duct. And as we have discussed, reflux of mucoid or mucopurulent material can be detected through the puncta on digital pressure over the lacrimal sac region. CNLDO may develop into Dacryocystocele or infection of the lacrimal sac, as seen here in this picture, with increased swelling of the lacrimal sac and inflammation of the overlying skin. Dacryocystocele should be treated with systemic antibiotics, and following resolution of Dacryocystocele from CNLDO, immediate probing should be performed. Congenital Dacryocystocele, also called mucocele, dacryocele or amniotocele, develops when both an obstruction at the valve of Hassner and obstruction of reverse lacrimal flow through a functional valve of Rosenmuller are present. The accumulated mucus in the lacrimal sac is secreted by goblet cells of the lacrimal sac. Dacryocystocele usually appears at birth or within first few months of birth, and it appears as a bluish swelling below and medial to the medial canthal tendon, as seen here in this picture. Dacryocystocele is initially sterile but is prone to become infected and convert into a dacryocystitis. What is important is the swelling of Dacryocystocele may extend intranasally below the inferior turbinate, as seen here in these photographs. Bilateral intranasal swellings occur in 20 to 30% of patients with congenital Dacryocystocele, and this may cause airway obstruction, as children are obligate nasal breathers, breathing through the nose and not using the mouth to breathe. Airway obstruction from Dacryocystocele needs emergency intervention, otherwise digital messaging may be attempted initially. If Dacryocystocele does not resolve within first 2 weeks of initiating digital messaging, probing should be done, and probing is curative in 75% of Dacryocystoceles. If in addition endoscopic intranasal cyst removal is done, 95% of patients with Dacryocystoceles are cured. Bilateral exploration is recommended because, as we have discussed, 20 to 30% of congenital Dacryocystocele patients have bilateral intranasal swelling. If acute dacryocystitis develops from a Dacryocystocele, systemic antibiotics needs to be given. Management of congenital obstruction in the nasolacrimal duct should start with digital messaging over the lacrimal sac area, and it is very important to make the patient's parents understand the exact location of the lacrimal sac area. Intermittent application of topical antibiotics may be required for mucoid or mucopurulent discharge, but prolonged application of topical antibiotics should be avoided to prevent emergence of drug-resistant strains of microorganisms. If digital messaging fails to relieve the obstruction in the nasolacrimal duct, probing should be done, and most recommend probing at 1 year of age, and this is very important to remember. because it has been found that success rate of probing decreases when probing is performed after 13 months of age. Probing is required earlier if dacryocystitis or nasal obstruction from Dacryocystocele occurs. And for probing, children 1 year or older require general anesthesia, but younger children can be probed under topical anesthesia. Steps of probing are as follows. Usually the lower punctum and the canaliculus is probed, the patient is immobilized and topical anesthesia is applied. Oxymetazoline spray is used to achieve intranasal vasoconstriction. Probing should be done gently so as to avoid creation of false passage. Probing begins with dilatation of the punctum with a punctal dilator oriented perpendicular to the eyelid margin. Bowman lacrimal probe size 0 to start with is inserted through the punctum perpendicular to the eyelid margin for 1 to 2 mm. The outer end of the Bowman probe is turned laterally so that the inner end of the Bowman probe advances medially through the canaliculus, and a finger of the surgeon's other hand puts lateral traction on the eyelid so as to straighten the canaliculus and reduce the risk of the Bowman probe perforating through the canalicular mucosa, creating a false passage. Normally, the probe passes without resistance through the canaliculus and the lacrimal sac to strike the medial wall of the lacrimal sac and the lacrimal bone, which is called a hard stop. Resistance in the canalicular region as well as in the NLD is called a soft stop, and resistance in the canalicular region is associated with medial movement of the eyelid and wrinkling of the overlying skin. When there is a soft stop in the canaliculus, the lacrimal probe can be removed and reinserted and lacrimal passage reprobed. After achieving a hard stop in the medial wall of the lacrimal sac, the external portion of the Bowman's probe is rotated 90 degrees superiorly towards the brow to make the external portion of the Bowman probe lie adjacent to the supraorbital notch. The Bowman's probe is then advanced inferiorly, posteriorly and slightly laterally through the nasolacrimal duct. This direction is very important to remember and corresponds to the normal anatomy of the nasolacrimal duct. On reaching the valve of Hassner, a resistance is felt and gentle pressure pushes the Bowman's probe through the obstruction at the level of the valve of Hassner. Conformation of passage of the inner end of the Bowman probe through the valve of Hassner can be done by either an intranasal metal probe producing metal-on-metal contact with the inner end of the Bowman probe, visualization of the inner end of the Bowman probe on the lateral wall of the nose 2 cm behind the nostrils with a nasal endoscope, or by injection of saline mixed with fluorescein through the punctum, but for this the airway needs to be protected by the anesthetist. False passages are more common with unusual anatomy and or coexistent infection. Patients with cardiac diseases should be probed under cover of systemic antibiotics, and a single appropriate probing procedure relieves congenital nasolacrimal duct obstruction in 90% of patients when probed at the age of 13 months or less. Resolution of CNLDO after probing takes 7 days to occur. Recurrence of epiphora, if it occurs, is evident within 1 to 2 months of initial probing, and recurrence of epiphora is more likely in patients with chronic rhinitis with complex CNLDO associated with facial cleft anomalies, or when the patient with CNLDO is probed for the first time beyond 36 months of age. And these patients require intubation, which we will be discussing next. If these conditions are not present, probing can be repeated successfully 3 months after the initial probing, but during reprobing, nasal endoscope is recommended to confirm complete passage of the probe through the terminal portion of the nasolacrimal duct. Occasional epiphora, as with nasal congestion, does not require any further treatment including probing. Intubation of the lacrimal passages with a lacrimal stent, as shown here in this photograph, is indicated when there is recurrence of epiphora following single or multiple probing procedure in patients with simple CNLDO, and during initial probing in older children and in those with complex CNLDO. The lacrimal stent is passed through the punctum up to the nasal cavity, where it is fixed, and the lacrimal stent can be either bicanalicular, as shown here in this picture, or monocanalicular, as shown here, and the stent is kept in place for at least 2 to 6 months. After an initial failed probing, lacrimal intubation has a 70% success rate, and complications of lacrimal intubation include corneal abrasion, migration of the stent, and cheese wearing at the level of the puncta, destroying the punctum and the proximal canaliculus. Inferior turbinate infracture is indicated when the inferior turbinate is lateralized against the opening at the distal end of the nasolacrimal duct, obstructing the drainage in the nasolacrimal duct and also obstructing the view of the opening of the nasolacrimal duct during nasal endoscopy. However, routine inferior turbinate infracture during every probing procedure has not been shown to improve outcomes. With the blunt end of a periosteal elevator placed within the inferior meatus, the inferior turbinate is rotated medially towards the nasal septum. In balloon Dacryoplasty, a balloon catheter is passed into the nasolacrimal duct and the balloon is inflated at the site of NLD obstruction. Indications of balloon Dacryoplasty are not well defined, but balloon Dacryoplasty may be useful in diffuse obstruction of the nasolacrimal duct. Dacryocystorhinostomy or DCR is indicated in congenital nasolacrimal duct obstruction when there is recurrent epiphora and dacryocystitis after probing and intubation, or when there are developmental anomalies of the nasolacrimal duct precluding successful probing and intubation. Thank you for listening.